Hello, welcome. My name is Dr. Prashant Muthukrishnan, Dr. Muthu. I am a pulmonary and critical care attending and researcher at WVU Medicine. And I had a wonderful opportunity in CHEST 2022 at Nashville, and I met with wonderful physicians in the airways disease network within CHEST. And as we are gearing up towards submissions for CHEST 2023 in Hawaii, I thought this is a great way to connect with one and all and try to see if we can collaborate. I'll be presenting a very timely and needed topic of discussion where we will be bringing in aspects of the aerodigestive medicine, which is a collaboration between GI, ENT, and pulmonary folks, and will be very useful for internal medicine primary care doctors as well. Case number one, a 70-year-old lady with history of COPD and a past smoking history, quit greater than 10 years ago, comes to us with a history of lymphoma and the most recent incidence of any chemotherapy was in 2019, and this is in the year 2022 that we're talking about. Shortness of breath and difficulty inhaling and exhaling was one of the main complaints for this patient, resulting in kind of spasms over past several weeks to months, right? So she comes to us for a second opinion. She says she feels better with cool air, fan in front, just like many other COPDers. No sensitivity to perfumes or dishes noted. Sometimes happens while watching TVs, but mostly on any exertion, dressing, cooking, etc. Sometimes it catches her off guard as well. Not improving with Advair, Duonev, Single Air, Keflex, Medrol dose packs. Eosinophils 0.16 to 0.28. Epworth score was low. She has a history of tinal hiatal hernia, mild GERD, and PPI as needed. We do an echocardiogram in the chart review showing mild left atrial enlargement, no pulmonary hypertension, EF of 65%, and nuclear stress was negative in the recent year. And you see the typical flow volume loop suggesting the history of COPD with an FEV1 of about 70% and a percentage change in bronchodilator response of 16%, as you see. And with a reasonable amount of DLCO reduction of 45% and TLC borderline 78%, right? So therefore, there's definitely a reasonable amount of emphysema, as you see on the CAT scans, and I'm not sure if this is more of a motion artifact, but also there's a very, very mild amount of haziness. The patient has already stopped smoking, right? And so in this kind of a case, what would you do for this COPD patient who comes in with shortness of breath with a particular set of types of complaints? Pulmonary rehab, is that going to help her? Exercise stress, will that help her? Because you can go back and see some of these situations where she gets short of breath. Sometimes it seems to be happening while watching TV. Well, usually that's not consistent with COPD or asthma, right? Inhaling and exhaling, right? Spasms. So what next? So she says discomfort and tightness in the chests. And then I notice in her clinic visit certain mannerisms that she does every few minutes. And she actually takes a deep sigh breath and uses accessory muscles like that. And so that made me think about a certain other list of differentials. Now let's briefly talk about the second case and see how different she is. 46-year-old female, shortness of breath, chest tightness for months, sometimes mild, sometimes severe and episodic, sudden, at rest sometimes, and at exertion. This is something that you need to watch out for, right? Sometimes at rest, sometimes on exertion. CBC with eosinophils of 0.20, sometimes 0.40, IgE normal. RAST panel for dust mite was definitely moderate level positive. So, could there be an asthmatic component, right? That's a question. And CT scan, stone cold normal. Exercise stress echo, She spent about 6 minutes, 7 mets, which is fair, and usually, she's able to reach about heart rates of, max of 164, 94% predicted, right? Normal blood pressure, and 18 mets was actually appropriate for her age, so she was actually not at her predicted met. So she basically requested for terminating the stress exercise stress echo due to limiting dyspnea. And actually, after the completion of the stress echo, she actually started hyperventilating, right? And the spirometry that you see, FEV1 is reduced 77%, 68% ratio, right? So there is definitely some component of obstruction, no bronchodilator response. The FEF25 75% is also slightly reduced. And then you also see PEF, peak expiratory flow, also seems to be reduced, right? Look at the flow volume loop, guys. Seems to be stunted, right? What next? So in such a case, yes, this is the topic of discussion today. ENT, bringing in ENT folks, and speech therapy. Those are two of the most important things that I will be talking about in this lecture today. Okay, so patient number 1, we send her to an ENT eval. True vocal cords show paradoxical vocal cord motion. Rest of the glottis and post-cricoid was actually normal, no edema. Recommended PPI or Pepsid, anxiolytic, and neurology referrals or CBT referrals. Possibly there's a component of anxiety or stress. That was the recommendation from ENT folks. Obstructive sleep apnea screening was done. Respiratory Event Index, REI, which is the equivalent of AHI for a home sleep study, was as high as 47. She actually scored low on the Epworth score, sleepiness score, but still you got a 73 REI while she was supine, and 47 was her REI, Respiratory Event Index, overall. So as of 2020, when we started her on a CPAP, right? As of 2022, she continues to struggle with the symptoms despite PPIs, despite CBT, using CPAP, now we're trying to get her actually a barium swallow, trying to see if the tiny idle hernia that I mentioned, has it become worse or not, right? And she actually mentions, oh, reflux, come on, it's totally under control. Yeah, you don't have to worry about it. Well, we'll see once the barium swallow gets done, right? We sent her to a speech therapy evaluation. Patient was able to read a selected passage for 1 minute, noted 19 audible air intakes with abdominal thoracic breathing. Patient was able to sustain this sound for an average of 5 seconds and Z sound for an average of 5 seconds. Z ratio was 1. Noted when the pitch was noted when patient attempted to sustain the voice was strained with slight diplophonia. She attempted to move up the musical scale with producing only 3 notes. Patient read sentences containing words beginning with vowels. No hard glottal attacks noted. Overall quality of conversation was strained. Loudness. Patient was unable to progressively increase loudness when counting to 5. Patient coughed several times after attempting voicing tasks. Noted patient would attempt to breathe through her mouth. When patient becomes short of breath, increased vocal cord adduction occurs, which results in spasms. Observed arms and upper body jerky movements when spasms occur. You see? So those are the mannerisms that I was talking about. Do you get this kind of a wholesome assessment when you see patients in your clinic who come in for shortness of breath? No, right? And that's what I'm hoping to hit the nail on the head here, that we need to go beyond asthma, COPD, and try to elicit certain history that actually helps the patient get to the right destination. Patient number 2 was also sent for ENT eval and fluoroesophagogram, which is barium swallow. Laryngeal movement, paradoxical vocal cord motions, again seen on this patient as well on inspiration, right? Vocal cords, and severe pachydermia, which I think is the word for swollen, arytenoid swollen, severe edema with active reflux. Note that this this patient, right, there was spontaneous, severe gastroesophageal reflux all the way up to the esophagus. And this patient was started on PPIs just like anybody else. And actually, they repeated an ENT eval in 3 months and 50% improvement in a reflux, but still severe reflux-related ENT changes. EGD with manometry, upper esophageal sphincter, normal resting pressure, impaired relaxation in response to wet swallows, lower esophageal sphincter, also normal relaxation, right? Barium swallow, right? Was done on this patient, and you can see the images right here. And you see barium nicely going through the esophagus. And I hope this will, help you start looking at barium swallows, opening these images in your own patient's chart. And right there, look at that, up the gradient, right? Movement, reflux up the esophagus, all the way into the upper cervical esophagus. And this is amazing when it actually gets caught during the barium swallow. Sometimes it's very hard to catch these events in a very short time. So that's your barium swallow that I was able to show. I'm happy we got that. Bravo study, which is a pH, ambulatory pH study, Demeter score of 3.8, super low, right? Longest time in reflux was just barely 10 minutes per day was the longest time over a 48-hour study. Non-severe reflux noted. However, despite the reflux being not so bad, based on the Demeter score, still she continues to struggle severely as of 2022, managing symptoms. So in this case, reflux seems to be objectively scored very low, but still has a lot of objective physical findings in her vocal cords. Therefore, in this case, I think that there is more than just reflux that's causing her vocal cord motion, and she continues to go into the ER multiple times, unable to catch her breath. And I really feel frustrated while taking care of these patients, and we hope to get more help on this. And I'm hoping that there are a lot of other people who are also understanding where I'm coming from in this audience. So patient number 2 was sent to speech therapy, no exposure to chemicals or allergens in her workplace, has high stress levels with her job, right? And that's one of the most important things I want to tell you guys. Ask people about how much stress they're going through. Are you taking on too many tasks for your day in your professional or social life? Do you get enough chance to rest and digest? Take breathing breaks during your workplace hours, right? So she reported that she experiences significant difficulty sleeping as well. So sleep hygiene or lack of sleep efficiency is such an important insult to the autonomic nervous system, right? More she talks, or the more she has to talk, the worse her voice sounds and more labored her breathing becomes. Difficulty swallowing, difficulty with her throat seizing up sometimes when drinking or eating. She also noted having pain, discomfort, and tightness in her throat, often feels the need to cough and clear her throat as well. These are questions that we don't sometimes ask our patients. It's pretty quick. Oh, asthma, COPD. We look for these two anchoring things and try to somehow give breathing treatments or inhalers and somehow get to the next patient. And I hope we go beyond these inhalers, because at least 20% of your clinic population is not COPD or asthma that you thought about, right? So her voice evaluation results: respiration, 5 audible inspirations during a 1 minute oral reading. Okay, multiple inspirations were observed beyond that. The patient appeared to struggle to breathe through the reading and was noted to speak on residual airflow at times. Significant shortness of breath was observed. Noted clavicular and thoracic breathing. Sustainment of sounds of the S and the Z sounds were actually average within normal limits for a female. However, the ability to maintain effective loudness of these sounds, notable, dropped following 8 to 10 seconds of production of the voice. Voicing was weak after that time. Pitch, not able to move effectively up or down the scales. Quality, no glottal attacks. Strained quality throughout the assessment. Loudness, not able to maintain efficient loudness, especially in a noisy environment. Noted to cough a few times during the assessment and significantly struggle for breath. So I've been hoping to create a program in WVU for such patients simulating things that are happening elsewhere. Cleveland Clinic under Paul Bryson, UPMC, I'm hearing that Andrew Petrov is actually working on these things. But the most amazing person that I would love to meet is Todd Olin at National Jewish. Amazing center where he has live flexible laryngoscopy, where the patients actually are on a treadmill and they actually get to see their own vocal cords doing the paradoxical movements, and they actually get live feedback mechanism so that they can start addressing their involuntary vocal cord motions. And a lot of athletes do have this problem, either due to significant amount of stress in their life trying to compete for events, or due to reflux and other situations. So points to consider: not all that wheezes or cough or shortness of breath is asthma or COPD. Please look beyond that. Don't try to find a reason to put a name of asthma or COPD on a patient until you are convinced. And if you are not convinced, please send the patient for a second opinion, right? Listen to the patient, understand their social and professional life. If stress is happening, you need to help the patient understand that and address that. Not all VCD or exercise-induced laryngeal obstruction patients will have objective evidence of PFT, like the flattening of the curve, or even during ENT exams. I have so many patients that don't have paradoxical vocal cord motion that have been identified during the time that my ENT guy looks at it, right? That doesn't rule the diagnosis out. Look into American College of Lifestyle Medicine resources. Amazing, certification program that I have certified myself in, created by Dean Ornish, the founder of Cardiac Rehab, who went on to get cardiac rehab approved by CMS many years back, right? Dean Ornish. And we have an amazing board of lifestyle medicine that's organizing national conferences called Lifestyle Medicine 2022. We attended that in Orlando in November every year. You can look into that. Please have close contact with speech therapy, ENT, reflux assessment, mindfulness meditation or transcendental meditation, relaxation, just taking a breathe break. That's all it requires to make a change in your autonomic nervous system hyperexcitation. Understand comorbid health conditions actually may stem from lifestyle habits, similar lifestyle habits. These patients, the patient number 2 has endometriosis and had to have her bilateral salpingo oophorectomy and hysterectomy. These are things that actually go along very well with each other, right? Hyper driven or hyper excited sympathetic nervous system. And then usually these patients are commonly women who have also vocal cord dysfunction, but we do see some of them happening in men too. Understand that comorbid health conditions stem from lifestyle habits, so therefore potentially fixing 1 or 2 lifestyle habits can actually have a major impact on many of your symptoms and diseases. Please do not underestimate GERD. When patients say, oh yeah, I take a PPI, it's all good. Most of the GERD is silent, right? And most of the times reflux happens mostly in the nighttime, and therefore patients do not have symptoms during the daytime. Clinic intake forms, if you have a checklist, should include things like hiatal hernia, reflux, and voice changes. And there we go. I wanted to show you about American College of Lifestyle Medicine. These 6 pillars of lifestyle medicine are very simplistic versions of lifestyle advice. However, sometimes simplifying lifestyle advice goes a long way in hitting patients in their own perspectives, right? Increasing physical activity, trying to find a personal touch to their own life and finding out how to improve physical activity. Not necessarily exercise, but there is a difference between exercise and physical activity or movement, right? Similarly, develop strategies to manage stress, understand and elicit history that actually makes them aware that they're actually stressed. Form and maintain relationships, improve your sleep, avoid risky substances. Again, I talk to my patients about nicotine and cigarette smoke and vapes and fumes. Finally, healthy eating. I'll be talking about Dr. Jamie Kaufman, who's written a best-selling author book about acid reflux and the aerodigestive medicine, and that talks a lot about recipes and various dietary modifications. I wanted to show you briefly about an amazing PDF document, 6 Pillars of Lifestyle Medicine, Bonnie Coyle, a deeper dive into plant-based eating, looking at chronic disease in the US. We are basically cleaning the floor without closing the tap. Some of these things like obesity, gastric bypass surgery, overweight children, teens with pre-diabetes, diabetes 2, fatty liver. This was not a thing in the past, and now it is. Esophageal cancer due to acid reflux, and so on. So most of chronic disease, 80%, right, is potentially reducible by becoming a non-smoker, maintaining a healthy weight, 5 fruits and veggies per day, exercise 30 minutes a day, 5 times a week, right? So this is an amazing PDF document that's available online, and I will share that with you at the end of this presentation. But along with that, there are also self-care handouts for physicians, and patients can use this, how to beautifully make it easier for them to understand what is lifestyle activity and so on, right? Activity goals, creating SMART goals is the way you bring people to understand how to make things simpler for them. Yeah, SMART, specific goal, measurable goal, attainable, relevant, and time-based. Pulmonary rehab is an amazing start to get all of this, because pulmonary rehab involves also dietary advice, smoking cessation, psychological counseling, and so on. So please try to find a reason to enroll your patient in pulmonary rehab. And there are certain Medicare diagnoses that need to be fulfilled for pulmonary rehab, and somehow I try to see whether my patients qualify for such diagnoses: asthma, COPD, restrictive lung disease, neuromuscular disease, chronic hypoxemic respiratory failure, and so on, interstitial lung disease, etc. All right, next case, buddy. 54-year-old lady, BMI of 37, hypothyroid on Synthroid, working in Walmart. Had to stop 2 years back, unable to breathe, getting more weight, fatty liver, IBS, right upper quadrant pain, palpitations, chest tightness. Referred for mild pulmonary hypertension to me with a right ventricular systolic pressure of 33 on echo from 2021. Has a history of using phentermine, which is a weight loss medication, for just 3 months. And so I said, okay, let's repeat an echo. Let's do all the testings to make sure that this is not pulmonary hypertension and all the organic structural diseases, right? Normal chest X-ray, normal CT chest, BNP normal, FEV1 88%, FVC more reduced than the FEV1, obesity possibly contributing, ratio of 80, DLC of 74 mildly reduced, borderline, normal loop, completely looking normal loop, right? 6-minute walk. On the day of the 6-minute walk, she walked actually pretty decent, 438 meters. That told me something. Wait, this patient has a lot of chest tightness. You're saying she's actually stopped working 2 years back because she's unable to breathe. But then today you're saying 6-minute walk is 438 meters. So there's something going on. That made me wonder, is it episodic? Right? She has a history of gallbladder hydroscan done that showed ejection fraction of 1%. Basically, gallbladder dyskinesia, functional dyskinesia. And guess what happens? It gets removed. Holter monitor, rare PVC. So no arrhythmias causing her palpitations, right? VQ scan, normal. Echo repeat, normal RVSP. So therefore, there's no pulmonary hypertension currently. Now, what do I ask her? What happened 2 years back when you stopped working? Did you go through some procedure? And then she says, yes, and it's not in the medical chart. She says, oh, I think I had an esophageal dilatation done at that time. Why? Because I had dysphagia? Okay. Guess what? I sent her to ENT. No vocal cord dysfunction this time. But guess what? She has one-sided, left-sided vocal cord complete paralysis. How could that happen? Well, I looked up literature search. Guess what? Esophageal dilatation sometimes has an uncommon side effect or a complication of vocal cord paralysis. Little did I know about that, right? maybe it had nothing to do with esophageal dilatation. Maybe this is a neurogenic dysfunction causing one-sided vocal cord paralysis. Sometimes there is post-viral syndromes that cause vocal cord paralysis, right? However, there was also post-cricoid edema noticed during the ENT evaluation, and there is laryngopharyngeal reflux, LPR, or respiratory reflux. That's what Dr. Jamie Kaufman mentions in her book. And right, so I asked her about, do you have reflux? She said, I don't think so. Well, we'll see the next case, and then we'll show you barium swallows. Next case, 55-year-old female, shortness of breath, sporadic, rest and exertion. That's a classic thing that you might want to ask your patients. Does it happen at rest? Right? And 2018, I go back, look at the history. For some reason, my eyes just somehow gravitate towards anything that has to deal with reflux, hiatal hernia, voice changes, and so on. Because I go beyond asthma and COPD, right? Because if the patient comes to me, they've already seen an internal medicine doctor, right? And therefore, I make sure that it's not the bread and butter first, but then beyond that, I start looking for clues. And I'm hoping you guys can also start looking for these with me. History of small sliding hiatal hernia, severe esophagitis in 2018. In 2020, gets a Bravo study, pH monitoring study, 48-hour study. 12.6% of the time out of the 48 hours was spent in reflux. That's a lot. Longest reflux event was 31 minutes, Demeister score of 47 with 66 episodes of heartburn. This was 2020. Ends up already getting a topet fundoplication in 2021, right? And she sees us in 2022 for the first time, pulmonary. Basically gets admitted to the hospital, goes through a cardiac catheterization for chest pain and shortness of breath, and clean cath, and then pulmonary is consulted. And guess what I'd say? Well, I don't think this is asthma. You never smoked. You had a secondhand smoking history of smoking, but still doesn't sound like COPD. I'm going to get an ENT eval. And guess what happens? There is no vocal cord dysfunction, right? And then I'm saying, damn, that's a bummer. Well, no, I don't give up. I get a GI person on board, and a barium swallow is done. Number 1, recurrent small paraesophageal hernia with ongoing reflux noticed. So paraesophageal hernia and vocal cord edema is noticed. There's another patient I wanted to talk about. Severe cough. Every few seconds in the clinic, she basically coughs. And then she talks for a few seconds. That's the way she coughs, right? And again, sent to ENT, paradoxical vocal cord motion, severe edema, 5 cups of coffee every day. We start requesting her, come on, let's cut down the caffeine. And beautiful improvements. Okay, so let's look at the patient number 1 that I talked about. Right there, you see in this one, yeah, that's the sliding hiatal hernia, and right there you see the contrast on the upper part of the foot pipe. After completion of the study, if you see contrast still in the esophagus, that usually means that there was a reflux event that propelled the reflux up. Okay, let's look at this one. Alrighty, here, so far so good. And then downward. And look at that upward movement of reflux towards the end. That happened right there. And look at this one. This is incredible. Okay. Look at that. That's a reasonable size hiatal hernia right there, right? So these are patients that are out there in the community, and we need to help them out by just getting the right kind of testing, okay? Now I'm going to talk about some mechanisms. So mechanism of gastroesophageal reflux in patients with obstructive sleep apnea syndrome. So some of these patients that I just mentioned, Even in the last two patients, one of them is being studied right now for obstructive sleep apnea. There seems to be a lot of correlation between obstructive sleep apnea, reflux, and hiatal hernia. And that's what I'm going to elicit right now. So these guys wanted to find out if there's a mechanism that connects reflux in obstructive sleep apnea. Sleep-related gastroesophageal reflux was mainly caused by transient lower esophageal sphincter relaxation, not because of the negative pressure that you create during the obstructive sleep apnea events, right? It's not by negative intraesophageal pressures during OSA events. It's because of relaxation events of the lower esophageal sphincter. That's a very important finding. During apnea events, the gastroesophageal junction pressure actually increased, not decreased, increased, synchronous to the intraesophageal pressure decrease. Right? Because over time, we keep pulling negative pressure and suck the stomach into the chest over time, anytime you have apnea events over years together. And that would make some wonder, or maybe that's why there is reflux events because of the severe negative pressure. No, it's actually because of what happens is obstructive sleep apnea patients had significantly more relaxation events during sleep related to the preceding arousal that they just had and shallow sleep. So the relaxation happens to be related to the continuous change in the level of their brain activity between sleep and awake state. And as they move from sleep to awake arousal, during that time, relaxation of the lower esophageal sphincter happens, and that seems to be explaining possibly the reflux events. Next, prevalence of hiatal hernia in 180 obese patients. This was a study. Mean age was 44 years, mean BMI, pretty decent obesity, right? 43 of BMI. And hiatal hernia was seen in 37% of these patients. In obese patients, not necessarily OSA, just obesity, 37% had a hiatal hernia. GERD, 39%. Moderate to large hiatal hernia, 4%. Moderate to severe GERD, 13.3%. Next, another study trying to again further explain what's going on. Study of 8 patients with OSA. Half of the night was done without CPAP and the rest of the night half with CPAP. Esophageal manometry and pH testing. Upper airway obstructive and nocturnal reflux events are not directly related. That's the finding from this study. They don't necessarily happen right after each other or at the same time. The relatively low barrier pressure in these obstructive sleep apnea patients raises the possibility of the weakening of gastroesophageal junction from repetitive strain associated with obstructive breathing events. The favorable effect of CPAP on reflux is possibly due to an increase in the nadir barrier pressure and decrease in the duration for which the lower esophageal sphincter relaxes during swallowed-induced and transient relaxation. So basically, they think that CPAP might potentially help by increasing the nadir pressure and decreasing the duration of the relaxation that I talked about. Another cohort in 2009 by ENT population, 42 adults with sleep apnea, and 83% of them had at least one GI finding, 59% had 2 or more GI problems. Most common, 64% hiatal hernia. Imagine 12 million Americans in 2009 had obstructive sleep apnea. And you can imagine the number of people who may have hiatal hernia. So this is an important disease in the community, and I hope we can connect sleep apnea, reflux, hiatal hernia, asthma, COPD, vocal cord dysfunction, right? And there's a one-stop shop. Lifestyle modification, weight loss, supporting them through their weight loss journey, and in the meantime, using medications such as PPIs and Pepsid to control their reflux, because still medications are important because we know that the end organ damage from reflux is esophagitis and cancer risks, and therefore that alone gets addressed by the PPIs and maybe some amount of symptom control. Reflux, the mechanical problem of reflux does not change with PPIs. It is literally the acid content of the stomach that changes in pH, but there is continuing ongoing reflux that happens in people who are still on PPIs. And that's where we need physicians to understand that prescription of PPIs is not the end of the game, especially for GI doctors and ENT doctors. Okay, if possible, just refer them to a lifestyle medicine certified physician in the area, and that might really help a lot. Mechanism of gastroesophageal reflux in obstructive sleep apnea patients. This was a study to find out, is it obesity that's affecting the risk for reflux, or is it apnea events that is affecting? And from this study, the number of reflux events between obese people with apnea and without apnea was same. So therefore, that suggested maybe obesity is the cause. Next, obese apnea patients had way more reflux events than non-obese apnea patients. Okay. BMI significantly predicted number of acid reflux events. So therefore, that's something that we need to look into. Obesity and hiatal hernia. We know that metabolic syndrome seems to go along with many other comorbid diseases, including asthma. And more we spend time with asthma, we understand that asthma may be a pulmonary manifestation of an extension of metabolic syndrome. And I'll tell you why. Obesity and hiatal hernia may actually be considered as non-allergic risk factors for eosinophilic esophagitis in Japanese adults. That was a study. Similarly, there's a thought that embryology may actually explain the reason why. Around 20 days of the development of the fetus, the gut tube, the blood tube, and the nerve tube are one of the most important core tubes inside the embryo that eventually manifests into the fetus. And guess what happens? Like a bow tie, around 24 days, the thyroid buds from the gut tube. The lungs actually bud from the gut tube, liver, gallbladder, and pancreas. So just as much as the pancreas, liver, and gallbladder are related to the digestive system, the mechanisms of metabolism or metabolism, the lungs and the thyroid have very much to do with metabolism. Therefore, sometimes sarcoidosis, for instance, can be seen very commonly in association with metabolic syndrome, right? And therefore, there is a concept suggesting that maybe eosinophilic esophagitis may be just the asthma of the esophagus. IgE-dependent activation of human mast cells and activation of human eosinophils seems to be actually controlled by the circadian clock. This is where I bring in the role of lifestyle or discipline, which is called the circadian clock, the body clock. And therefore, we're trying to figure out how obesity, how metabolic syndrome, asthma, eosinophilic esophagitis are all correlated to each other. There are multiple studies that showed that circadian disruption was very common in patients with eosinophilic esophagitis. And we know the Nobel Prize was given to 3 amazing scientists for discovery of the mechanisms controlling circadian rhythms, including Jeffrey Hall. Very similar to the Nobel Prize findings, for many centuries together, we have known, not just in Ayurveda, but also in traditional Chinese medicine, Greek, Roman, Egyptian medicine, the importance of circadian rhythm and the impact on health. Each of us has a body-mind constitution that is determined by the proportion of elements that make us, which is air, space, water, fire, and earth. And therefore, I defer to you guys to look into core concepts raising from Ayurveda to understand what are the things that you're doing that can disrupt the biological clock, similarly disrupt the balance of the 5 elements. And some of the impacts of stress happen through the disruption of the biological clock. And more importantly, the biological clock is what controls the health of the microbiome, which controls eventually the role of the immune system, the Th2 as well as the non-Th2 inflammation that happens in diseases including asthma and so on. The nervous system, the autonomic nervous system, controls so much of the aerodigestive system, the combination of respiratory and digestive system. So that's where lifestyle comes to play in the control of these symptoms. And there are certain seasons in which you are supposed to consume certain kinds of foods and certain daily routines and seasonal routines, and these are all available all over the internet. If there's one slide that is so important in this entire lecture, it'll be the vagus. Guys, the vagus nerve is one single nerve that controls so much of the respiratory and the digestive system. Imagine the chest and the abdomen. That's almost half of your entire human physique. Laryngospasm, bronchospasm, asthma, paradoxical vocal cord motion, neurogenic cough, throat burn, odynophagia, odynophonia, vocal cord paresis, reflux, heartburn, swallowing, and sphincter dysfunction. All of these are controlled by vagus nerve. And guess what? Most of us are insulting the vagus autonomic nervous system in the form of the fight or the flight activation, which happens all through our lives unless we stand up for it in the form of rest and digest. And being physicians, it's very common for us to be in a constant mode of fight or flight, but it gives a lot of benefit to try to find times where you can actually calm down the sympathetic nervous system, actually activate the parasympathetic nervous system. And this will go a long way in helping your patients. This is the questionnaire that I usually ask my patients. This actually comes from Dr. Jamie Kaufman, who's a pioneer in the field of aerodigestive medicine, which is ENT plus GI and pulmonary, all by a single physician. Glottic closure index suggests the risk for vocal cord as a potential cause of your patient's problems. Reflux symptoms index indicates the likelihood for reflux, and this one, chronic cough index, has 5 points each for reflux versus neurogenic cough. And in the past 5 to 10 years, there's increasing use of amitriptyline as well as gabapentin for neurogenic cough that stems from various diseases, including high stress situations, post-viral neuralgia, post-viral cough syndrome, and so on. And I use this. If you score more points towards reflux, then you're likely to benefit from seeing somebody like Dr. Jamie Kaufman, which I am introducing here in the form of a beautiful video YouTube page and also 2 amazing best-selling books. There's a lot of literature on YouTube with physiotherapy, chiropractic practitioners and physiotherapists that help to address acid reflux. Key points to consider as I end this talk. I'm hoping this would have encouraged you to try to see if you can join me and being available for chest and trying to see if we can split this entire presentation into 3 parts and see if we can create some content for our audience. Not all that wheezes or is short of breath is asthma or COPD. Listen to the patient, understand their social and professional life, find out if they're stressed. Not all VCD or exercise-induced laryngeal obstruction patients will have objective evidence of PFT abnormalities or ENT at the time of evaluation. Please look into American College of Lifestyle Medicine resources for lifestyle modification, close contact with speech therapy, ENT, and reflux assessments. Very important. Even thoracic surgeons are very good in reflux events. There's a newer form of minimally invasive procedure called the LINX procedure, which is a band that keeps the lower esophageal sphincter nice and tight. Please look into that. LINX procedures. Mindfulness meditation, relaxation, slow down, breathing breaks, understanding comorbid health conditions that stem from similar lifestyle habits, including people like type A personalities who are always on the move, moving from one task to another and unable to find time for rest and digest, as against the other kinds of people who are more grounded with increased amount of time spent without activity, right? Both have their own consequences. The clinical forms that you use for intake when you take in patients, kindly consider including questions about hiatal hernia, reflux, scoring systems, and voice. It is indeed a pleasure and a privilege to share this content with you. I hope to meet one and all of you to collaborate further. Thank you guys.